Timing of ovulation and intrauterine insemination. Intrauterine insemination, or IUI, is a less invasive fertility treatment in which the sperm is washed, concentrated, and a fine catheter is used to deliver motile sperm directly into the uterine cavity near the time of ovulation to increase the chances of fertilization. Ovulation induction agents such as clomiphene citrate, letrozole, and gonadotropins may sometimes be used to stimulate the women's ovaries to produce eggs. Intrauterine insemination is used most often in couples who have the following indications: mild male subfertility, unexplained subfertility, ovulatory factor infertility, experience difficulty with sexual intercourse, and/or the use of donor sperm. It is only suitable if the women's fallopian tubes are normal and not blocked. This will require either imaging via a hysterosalpingogram or a diagnostic laparoscopy to demonstrate that the tubes are patent. Hysterosalpingogram is an X-ray procedure with special dye inserted through the cervix to look at the uterine cavity and check the patency of fallopian tubes. Secondly, at least 1 million forward-moving sperms have to be obtained from the sperm sample on the day of the intrauterine insemination to ensure the likelihood of success. Before the intrauterine insemination procedure, both the patient and her husband will undergo a series of fertility tests, including blood tests to check ovarian reserve, female hormonal function, immunization status to rubella and varicella, and screening for infectious diseases such as syphilis, hepatitis B, C, and HIV. The doctor will also assess the patency of fallopian tubes through a hysterosalpingogram or hydrotubation during laparoscopic surgery. Semen analysis is also conducted to ensure there is enough sperm to proceed for insemination. If there are signs that suggest no ovulation, such as irregular periods, oral medications may be given for the woman to be taken from day 2 to day 6 of her menses to stimulate the ovaries to produce 1 or 2 ovarian follicles. The success rate of every cycle of intrauterine insemination is about 5 to 10%, and more than one cycle may be required to succeed. If intrauterine insemination does not result in a successful pregnancy, the fertility doctor will discuss the next best course of action. A series of transvaginal ultrasound scans will be done from day 12 of the menstrual cycle in a woman who has 28-day cycles to monitor the growth of the ovarian follicle and estimate the likely day of ovulation. The ovarian follicle is expected to grow at 1 to 2 millimeters per day. Once 1 or 2 follicles have reached a size of about 17 to 18 millimeters, an injection of recombinant human chorionic gonadotropic hormone will be administered to simulate the luteinizing hormone surge, which matures and stimulates the release of the egg from the ovarian follicle. The intrauterine insemination will be performed 36 hours after the injection. If fresh semen transfer is planned, the husband will be required to submit a semen sample to the andrology laboratory on the morning of the insemination. This is to process, select, and concentrate the most motile sperm for the intrauterine insemination. The actual insemination of the prepared sperm sample into the uterine cavity takes about 10 minutes. A speculum will be used to visualize the cervix. A thin catheter will then be used to inject the sperm directly into the uterine cavity. This is sometimes done under transabdominal ultrasound visualization. After the intrauterine insemination procedure, the patient can carry on with activities of daily living after the procedure. A pregnancy test will be performed about 3 weeks after the procedure. Complications of intrauterine insemination are rare but include infection and bleeding. Ovarian hyperstimulation syndrome and multiple pregnancy are uncommon and tend to occur if ovulation induction agents are used. Multiple pregnancy may occur if procedure is performed when 2 or more ovarian follicles are present. Women with multiple pregnancy may face higher risk of miscarriage, fetal anomaly, low birth weight, preterm delivery, complications during birth, and postpartum hemorrhage. The incidence of multiple pregnancy also increases with the use of ovulation induction agents, especially gonadotropins. Thank you for watching this video. This video is presented by Yongloo Lin School of Medicine's Department of Obstetrics and Gynecology. For more videos like this, head on to the National University of Singapore's website.